Hello again, everyone. Let's get ready for day 3. So, day 2, you have completed an introduction to the infection chapter as a webinar. You've done an introduction to the endocrine system as a webinar. I've provided you with the recording of both of these for all non-members. For members, you can watch this on your platform. And then I asked you to go over calculations module 1, which had 12 videos covering every single type of question that can come up in the exam. And this was delivered by Enketia. For non-members, I gave you access to 2 of these videos. And hopefully as self-directed learning, you got access to examples of calculation questions that you had from any other sources, to go through all different types of questions. So in total, you should have done 10 questions from day 1, 12 questions for day 2, so 22 questions in total. For members, you can follow the plan. For non-members, follow the same plan that I tell you, but of course, utilize the resources that you have at hand to go over these topics. My main aim with these videos is to check your understanding. So even if you go over the infection chapter through using the BNF, what I will do is I will use these as pit stops to check your understanding and give you questions on the topics to see you understood everything. So what do I want you to go through today? Well, I want you to go through the endocrine system. So in particular, I want you to watch the content in relation to the introduction to the endocrine system and the insulin therapy video. For non-members, I want you to go over the introduction of the endocrine system as it is in the BNF and go over all different types of insulins. So you should have an understanding of what's going to be covered in the endocrine system. You should cover diabetes insipidus and also the all insulin therapies. And then when it comes to the infection chapter, go over the introduction, which includes basics of infection. A lot of that I've covered in the previous video on YouTube, so day 2. And then going over all antibiotics. So introduction, the basics of infection. So this is how it would look like on your MicroPharm membership, if you remember. But of course, you can use this as a guide as a non-member to see what you should go over in the BNF. Introduction, understand the basics of infection, principles of therapy, understanding OTC infection treatments, treatment for tuberculosis, sepsis, infection in terms of antibacterials. So go over penicillins, diaminopyrimidines, tetracyclines, quinolones, metronidazole, cephalosporins, clindamycin, and macrolides as a starting point. And then I want you to go over 10 example calculations. In this video, I'm going to give you 2 videos, following on from the 2 that I gave you in the last video. So 2 example calculations in this video, just to give you a good understanding of calculations. Okay, but in total, I want you to, if you're a non-member, I want you to go over 12 in total, so 1 of each type. I think I may have said 10, but I want you to go over 12. There's 12 different types of calculations that can come up in the exam. I want you to go over all of those. So after you've done that, you should be able to answer these questions. So the first question is, which of the following is a side effect of metformin? So is it A, hypoglycemia? Is it B, weight gain? C, gastrointestinal upset? D, edema? Or E, hepatotoxicity? So if you got the correct answer was C, gastrointestinal upset. And this includes nausea and diarrhea. In particular, the diarrhea is more prominent, but it's transient. So it tends to tends to come on when people start therapy, but tends to resolve over time. Next question. Which of the following antidiabetic drugs is most associated with a risk of hypoglycemia? Is it A, biguanides, B, sulfonylureas, C, thiazolidine diones, D, DPP4 inhibitors, E, SGLT2 inhibitors? So you should be able to name examples of all of these classes of drugs from your knowledge and from what you've covered. The correct answer was B, sulfonylureas. The way sulfonylureas work is that they increase insulin secretion, leading to a higher risk of hypoglycemia compared to other classes like metformin. The one that's closest to sulfonylureas is DPP4 inhibitors because they inadvertently increase insulin secretion, but hypoglycemia is more prominent with sulfonylureas. Biguanides decrease something, so metformin decreases something called gluconeogenesis, so the formation of new glucose from non-carbohydrate sources, so it decreases that formation of new glucose and improves insulin sensitivity, and it also prevents the production of more glucose via the liver. Okay, so thiazolidinediones again improve insulin sensitivity. DPP4 inhibitors, I told you about DPP4 inhibitors. By inhibiting DPP4, they prevent incretin breakdown. Incretin is a hormone that increases insulin production, and therefore inadvertently they increase insulin production. SGLT2 inhibitors increase the amount of glucose that's secreted from your urine. Which of the following insulins is considered rapid-acting insulin? A, insulin glargine, B, insulin aspart, C, insulin detamir, D, insulin NPH, and E, insulin degludec. As you know, from those of you who sat the June assessment, you will get brand names in the assessment. I generally don't give brand names when we're practicing, just to make it slightly more difficult, so it gives you more familiarity with these names and how they associate with brand names. Correct answer for this was B, insulin aspart. Brand name Novorapid or Fiasp. Which insulin is classified as a long-acting insulin? A, insulin Lispro, B, insulin aspart, C, insulin glargine, D, insulin regular, or E, insulin NPH. By insulin regular, sometimes it will come up as soluble insulin. You get an example of a soluble insulin. So from this, the correct answer is C, insulin glargine. This insulin glargine no longer has patent. The most common insulin, which was insulin glargine, was Lantus. Now you can get Semglee, and you can also get Toujeo. Which of the following statements about pre-mixed insulin formulations is correct? A, they are designed to be given once daily. B, they consist of a mixture of rapid and long-acting insulins. C, they provide both basal and bolus insulin coverage. D, they are recommended for use in type 1 diabetics. Only for use in type 1 diabetics. And E, they do not require mealtime coordination. So for this, the correct answer was C, they provide both basal and bolus insulin coverage. They are given twice a day, that's why A is correct. A is incorrect. The reason why B is incorrect, it's a combination of rapid and intermediate acting insulins. D, it's incorrect because it can be used for type 1 and type 2, and they do require mealtime coordination. Which of the following insulins is most appropriate for use in an insulin pump? Glargine, degludec, Lispro, NPH, or detamir? Okay, so the correct answer for this was insulin Lispro. It's a rapid-acting insulin. Rapid-acting insulins are used in insulin pumps. There's only one type of insulin that's used in an insulin pump, and that's it. If it's released out slowly, that gives you your background coverage. And then when you're going to have a meal, then you inform the pump how many grams of carbohydrates you're going to consume, and then following on from that, it will give you a bolus. Which antibiotic is the first line for uncomplicated urinary tract infection caused by E. coli? Nitrofurantoin, vancomycin, linezolid, metronidazole, or rifampicin? The correct answer for this was A, nitrofurantoin. If it's between nitrofurantoin and trimethoprim, what would you pick? Have a think. The correct answer for this would still be nitrofurantoin, and that's because trimethoprim has high rates of resistance. So if you look at the BNF, you can only use it when you're confident there will be a lower rate of resistance. So if you're using it empirically, that means without microbiology culture and sensitivity testing, then it would be nitrofurantoin. Which of the following antibiotics is a macrolide and is effective against atypical pathogens such as Mycoplasma pneumoniae? Is it A, doxycycline, B, ciprofloxacin, C, azithromycin, D, amikacin, or E, metronidazole? The correct answer for this was C, azithromycin. It's an example of a macrolide and can also be used. Other macrolides include clarithromycin and erythromycin. Okay, now following on from this, I'm going to play a webinar recording that includes more examples of questions that you can go through. And at the end of the video, I will give you a demonstration of Pro Plus and what's included in the Pro Plus membership. I hope you found this video useful, and I will see you tomorrow for day 4. We're going to use the poll function a lot in this webinar, so please feel free to use the poll function whilst in this webinar. It's completely anonymous, so no one can see your responses. We're going to focus and go through 8 single best answer questions. So, question number 1. Let's launch the poll. Mrs. Patel, a 37-year-old woman, visits her GP and is diagnosed with acute otitis media. She has a penicillin allergy and develops a rash when she takes penicillin. She is 25 weeks pregnant. What is the most appropriate treatment for her acute otitis media? Okay, let me share the answers. The majority of you have answered. Okay, so let's go through the answers. The correct answer is D. Let's go through why. So why should we not give this patient amoxicillin? Absolutely, penicillin allergy. So what does that rule out in terms of the penicillin allergy from your options? Absolutely, A and B are ruled out. A, amoxicillin, B, co-amoxiclav, which includes 2 things, amoxicillin and clavulanic acid. What does clavulanic acid do? Just for our own learning. It augments the action of amoxicillin, but it does this in a very smart way. It prevents the breakdown of amoxicillin, absolutely. So it's a beta-lactamase inhibitor. Yes, just as Julia said. Beta-lactamase inhibitor, what that means is beta-lactamases are enzymes that bacteria produce as part of their defense mechanism. So as part of their defense mechanism, they produce these beta-lactamases, which are considered like the mini soldiers that are produced by the bacteria to kill antibiotics. Now, the beauty of clavulanic acid is it's a beta-lactamase inhibitor. It's sort of, we could consider it as holding those soldiers in a headlock to allow amoxicillin to do its thing. So it prevents the beta-lactamases from breaking down the amoxicillin. And therefore, the amoxicillin is free to act against the bacteria. Now, the first two are ruled out because of the penicillin allergy. Would we give vancomycin? Why would we? What would we normally use vancomycin for? Yeah, used for a variety of different things. So vancomycin can be used for infective endocarditis. In some cases, can be used for sepsis. It can be used orally for C. difficile. It's the first line for that. Absolutely. There's no indication for it being used for acute otitis media. Now we're down to clarithromycin and erythromycin. So I can see a lot of you have selected erythromycin. What made you select erythromycin? So erythromycin has a much better safety profile when given to pregnant women. And that's why erythromycin is generally the antibiotic that you will see most used for pregnant women. From our options, the most suitable option in pregnancy and the penicillin allergy is erythromycin. Mr. Ivory has been prescribed doxycycline for the treatment of cellulitis. Which of the following is not a side effect of doxycycline? Okay, so the large majority you put down C, which is increased appetite. So that's the correct answer. C is the correct answer. Let's go through why C is the correct answer. So there's a few reasons for this. The first one is in terms of photosensitivity. Tell me more about photosensitivity. What does that mean? Yeah, sensitive to light. Patients can develop a rash. Increased sensitivity to sunlight, patients can develop a rash because of this increased sensitivity to sunlight. What would we advise patients to do when they're on doxycycline? Sunscreen with a high sun protective factor, even if it's a cloudy day, absolutely avoid sunbeds. If you're avoid limit exposure to sunlight is really important. So if you can limit exposure to sunlight, cover up as much of your skin as possible, so less of your skin is exposed to the sun. Nausea is a very common side effect reported by patients taking doxycycline. Quite often, it decreases your appetite rather than increasing your appetite. D, in terms of benign intracranial hypertension, it's a rare but a documented side effect of doxycycline. You want to be mindful if a patient has visual disturbances. You want to counsel patients on, particularly if they develop a severe headache whilst being on the medication, just to get this checked up and ask for a medical opinion. Also, oral disorders as well. So it can cause mouth and throat irritation. So that's another thing that's associated with the use of doxycycline. Next question, Mr. Manchester brings in a dental prescription to your community pharmacy. Which of the following cannot be prescribed by a dental practitioner on a FP10D prescription? Okay, let's share your answers for this. The results from this are always extremely interesting. So it's between vancomycin and temazepam. So we need to look at this rationally. We need to look at what would we expect dentists to prescribe and why. So for those of you that said temazepam should not be prescribed, what is the reason and the indication that a dentist will be using vancomycin for? Anyone? I think it was just there's a, so it's a tough one. So there's actually pretty much there's no true indication for them to be using vancomycin. And that's why, and particularly most vancomycin indications need intravenous or intramuscular vancomycin. And that's why you're much less likely to see a dentist prescribe this. So vancomycin was actually the incorrect answer. And the reason why I was asking you that question is I was trying to challenge your beliefs as to why it would be used, because a dentist giving you an IV of vancomycin, logically, that should ring alarm bells. But you can only understand that when you truly understand the indications for different medications. Why would they use temazepam? Because a lot of people thought temazepam was incorrect. It's for surgical procedures or for procedures, but what are they trying to manage? Sedation because of anxiety associated with dental procedures. So it's not used, it won't be used all the time. They can use it when someone is severely anxious of a procedure. Mr. Allen, a 25-year-old patient, presents to the accident emergency department with a dog bite. He is assessed and the decision has been made by the medical team to prescribe him antibiotics. He has no medication allergies. Which of the following would be the first-line treatment for a dog bite? It does indeed, Julia. So it does have to go on a CD prescription from the dentist. So I should have clarified that. Okay. While people are answering this, I'm just going to answer another question that I got privately. So in the question like the first one, if a patient has a penicillin allergy, do you assume that the rash is bad and therefore it's a true allergy, or do you challenge the allergy? If you've got that information about the patient's penicillin allergy, you would have to assume that it's a true allergy, if it's telling you that in the question. There are some circumstances where the GPhC will ask a question to ask you what is a true allergy when it comes to antibiotics. And what they're trying to ask you in those kind of questions is they're looking at side effects associated with antibiotics, like amoxicillin, for example. And they then they'll give you side effects like nausea or diarrhea associated with amoxicillin, or a rash or shortness of breath. And they'll want you to differentiate between a true allergy and a side effect. So just another point to keep in mind. Let me share the answers for this question. So got a bit of a mix here, but most of you answered B. The correct answer was B. Does anyone know why the correct answer is B? Maybe you've come across the fact that Comox Cloud is the first line. Do you understand why? Yeah, exactly that, Evelyn. So example of a true allergy is if a patient has difficulty breathing, or they have swelling of their throat. An example of side effect would be diarrhea associated with amoxicillin. Essentially good antibiotic cover, but there's something specific. Absolutely odd. It's aerobic and anaerobic cover. And the reason why that's really important is when you have a dog bite, you have to consider the types of bacteria that reside in the mouth of the dog. And it's polymicrobial. It means there's a lot of different bacteria within the mouth. And this specifically could be either aerobic or anaerobic bacteria. So it's very important to cover aerobic organisms. So amoxicillin gives you great cover against aerobic organisms. It gives you some cover against anaerobic organisms, but not as comprehensive in terms of cover as Comoxiclav. So it has a much broader spectrum of activity, and therefore Comoxiclav is often recommended for a dog bite compared to amoxicillin. So there you can see the majority of you have put answer, which is B. Okay, so Mrs. London brings in a prescription for methadone hydrochloride in the 2001 regulations. Drugs are divided into 5 schedules. Which schedule does methadone belong to? Okay, let's share your answers. So everyone has put Schedule 2, which is correct. So methadone belongs to Schedule 2 when we're considering CD classification. In terms of Schedule 2 controlled drugs, this schedule includes substances that have legitimate medicinal uses, but there's also a high potential for it to be abused or for patients to become dependent on these medications. So that's the reason why methadone falls under Schedule 2. Let's move on to the next question. Mrs. Williams is diagnosed with type 1 diabetes mellitus and is commenced on insulin. She's counseled on the side effects of insulin. Which of the following is not a side effect of insulin? Okay, for this, the correct answer was weight loss. So insulin can cause edema. It's a common misconception. What I'm going to do, I'm going to provide you the link of where you can take a look at insulin side effects. So there is a monograph for insulin, all insulins, in the BNF. And one of the most common side effects associated with insulin is edema. It can cause lipodystrophy, and it can cause lipodystrophy. It can cause hypoglycemia. So just to go through some of this terminology. So hypoglycemia, of course, is low blood glucose levels. Insulin, as I said in the previous diabetes webinar that we covered, insulin is a key, a hormone that is essentially a key that opens up access to your cells for your glucose that's in your blood. The glucose in your blood can then make its way into the cells. So because all of this glucose in the blood is now being used up, if you give yourself too much insulin, this can lead to low blood glucose levels for type 1 diabetics. And lipodystrophy is localized reactions at the injection site. So it can cause these either lumps or indentations at the injection site associated with insulin use. So particularly when patients are starting insulin, this is when edema, patients can have edema. So they have some level of fluid retention associated with initiating insulin. And there are skin reactions. So in some cases, you can have some redness or irritation or an allergic reaction at the injection site. Weight loss is not typically a side effect associated with insulin. Weight gain can be a side effect associated with insulin use, however. Let's move on to the next question. Mrs. Smith has been prescribed long-term steroids. Which of the following is not a side effect of corticosteroid use? Okay, let's share your answers. So we've got really a split between Addison's disease and muscle wastage. So let's go through all of our different options. So when it comes to diabetes mellitus, long-term corticosteroid use can increase and elevate your blood glucose levels. This can potentially trigger or exacerbate diabetes. So something to keep in mind when patients are on long-term steroids. In terms of osteoporosis, long-term use of steroids can lead to a loss of mineral bone density. This increases the patient's risk of osteoporosis. I can see none of you answered osteoporosis. Weight gain is something that's commonly seen with corticosteroid use. In particular, it can stimulate and increase your appetite. And ultimately, this has a profound impact on your weight. So quite often you will hear patients complain of when they're on long-term steroids of putting on a lot of weight whilst being on steroids. In terms of Addison's disease, what is Addison's disease? So it's because of adrenal insufficiency, not having enough cortisol being produced by the glands. So in particular, you will use corticosteroids. So you'd use steroids to treat Addison's disease. Quite often you would want to use something that's rapid acting, and we'll go through that in our endocrine system session. So you'd quite often use hydrocortisone when it comes to someone in adrenal crisis. So if someone's got such an insufficient level of cortisol that they're going to die. And muscle wastage. So muscle wastage can occur over time, particularly when patients are on long-term steroids. Let's move on to the final question. So the final question is a 56-year-old patient, Andrew Smith, presents to the cardiorespiratory ward with chest pain that occurs on exertion. He is diagnosed with stable angina. Which would be the most suitable treatment option to prevent further episodes of chest pain? So remember, this is prophylaxis of him having another attack of his angina. So for number 7, it was Addison's disease was not a side effect associated with corticosteroid use. So this is the moment that you've been waiting for. So let's check out the most popular course for the MicroPharm platform. So the two most popular courses are the Pro Plus and the Pro Plus Mentor. By far, it's the Pro Plus that's the most popular with students. So let's go through both of these memberships in today's video. So MicroPharm is an online platform designed for trainee pharmacists in mind. So we've got 4 tiers when it comes to our memberships, and we've trained over 5,000 trainee pharmacists so far. So we've got Essential, Pro, Pro Plus, and Pro Plus Mentor. The Essential has 3 calculation modules and over 300 videos and your webinar recordings. The Pro has 5 calculation videos, 300 videos, over 300 videos, approximately 400 at this time, over 600 GPhC style questions, and webinar recordings. The Pro Plus and the Pro Plus Mentor, which is what we'll go through in this video, has over 400 videos, webinar recordings, 5 calculation modules, over 800, so currently 850 GPhC style questions, which include both the clinical and also the calculations. And also it includes everything in relation to OTC and pharmacy law, and a pass guarantee. And the pass guarantee means that if you complete all the lessons, answer all the practice questions correctly at least once, and do not pass the June assessment, and this also includes the November assessment, we will provide a full refund because we're that confident. So at that point, if you've completed all of the content and you do not pass the assessment, we'll provide either a full refund, or if you want to, we can extend your membership for 12 months and guide you through the reassessment. We have a 98% pass rate for all members that have completed the course, and in particular, those on our mentorship plan, we have 100% pass rate. So everyone who is a Pro Plus mentor has passed the GPhC assessment. So how does the Pro Plus and Pro Plus mentor differ? Well, the main difference between the plans is we have one-to-one monthly mentorship sessions, and that's where I will create a bespoke study plan for you, and I will test you on the content that you have studied every month leading up to the assessment. Those that were on the Pro Plus mentor plan completed all of their content 2.5 months prior to the assessment, and the 2.5 months prior to the assessment, we were just revising content leading up to the assessment. So one of the trainee pharmacists on the platform that I mentored, for example, he got in the assessment, he got 34 out of 40 when it comes to calculations. You need 25 to pass, and 109 out of 120 for the clinical paper, and you needed 83 to pass for that paper. So the community page is a page that all members on the 4 tiers have access to, and this is how I update you about anything that's upcoming for the assessment. So anything that's upcoming in terms of upgrades to the membership, any additional modules, I will let you know on this page, and any additional upcoming webinars, I'll let you know on this page. In terms of products, you will see 2 things. So this is my master account, so that's why you can see everything. You'll see 2 things on your membership. You will see the Pro Plus membership, the MicroPharm Pro Plus membership that you see over here, and you will see Calculations Pro. So the Pro Plus membership will include, so if you click course, this brings you back to the entire course. You will see guidance on how to use your membership, a demonstration on how to use the membership, and also your roadmap. If I click over here, you will be able to see the roadmap. So the roadmap is here, and this roadmap gives you guidance on how to prepare for the assessment, monthly guidance on how to prepare for the assessment. So what I would recommend for you to watch every month. Back to the membership, you will have access to all of the webinar recordings. So all previous webinars, you will be able to access the recordings. Here is the OTC module, which is a 5-hour module, a very intense module to prepare you for the OTC aspects of the assessment. Eyes, ear, nose, and oropharynx, which is low weighting, but again, we give this dedicated about an hour's worth of content. The infection chapter, which we have in subsections because it's such a big chapter. It's also a high weighting topic and high weighting therapeutic area for the assessment. Skin, low weighting, but again, we dedicate an hour towards this. Both of these videos are approximately 20 to 30 minutes each. Gastrointestinal system, this is a 13 lesson video. We also include notes for all high and medium weighting topics. We have 18 study guides in total. Immune system and malignant disease, blood and nutrition, CNS. Again, CNS we've put into subtopics because it's a massive chapter. Then this will lead us on to pediatrics, respiratory system, so asthma and COPD, allergy and cough and cystic fibrosis, endocrine system, again, subtopics, massive chapter. We have the cardiovascular system, again, in subtopics, genitourinary system, medium weighting therapeutic area. We have some extra bonus materials or consultation skills for pharmacy practice, what to expect if you're ever moving into hospital pharmacy. We have 2 modules dedicated to pharmacy law, so an introduction to pharmacy law, and also the MEP covered thoroughly. These are covered separately by 2 of our educators. We have the musculoskeletal system, low weighting topic, but a big topic nonetheless, and therefore we dedicate 12 videos to this topic. Anesthesia, low weighting, but again covered well. Vaccines, 7 lessons dedicated to vaccines, low weighting topic, and 18 study guides. So every time I'm saying low, medium, and high weighting, if you haven't looked at the framework yet, I'd advise you to look at the GPhC exam framework. It tells you um, which therapeutic areas would be graded as either high, medium, or low weighting, and this weighting determines how much of the assessment is associated with low, medium, or high weighting material. Then you get practice questions. So you get 450 practice questions in total, in mixed exam format essentially, and then you get 300 questions that are divided into each therapeutic area. So the CNS, infection, cardiovascular system, endocrine system. So I missed that at the top. Blood and nutrition, respiratory system, pharmacy law, gastrointestinal system, genitourinary questions, over-the-counter questions, immune system, malignant disease, and also low weighting questions here at the bottom. So we have 300 of these questions in total with answers and rationales. This is what the study guides will look like. So this is an example of the infection study guide, and you can see we cover the material well. We have it's a 56-page study guide covering what we feel you need to know for the GPhC registration exam, and you'll have 18 ebooks and study guides in total in the Pro Plus membership. So alongside this, let's not neglect the calculations aspect of the assessment. So as you can see over here, we have the Calculations Pro that's included in the membership. This gives you 5 modules in total with a bonus module from Addy. So that gives you 70 videos where we give you examples of GPhC style calculation questions that we include the working out for. So that's 70 videos in total. And at this current moment, we have 100 calculation example questions with rationales and working out for the calculations aspect. And we are building 100 more questions over the next month. So by September 2024, we'll have 270 questions in total. 200 as calculation questions and 70 videos with unique questions that are not included in these calculation questions, unique questions to prepare you for the calculation side of the GPhC registration assessment. Throughout the year, we hold 20 live webinars, and you will get access to those webinars and access to those webinar recordings. So this is our most popular course, and for good reason. So hopefully you found this video useful, and all the instructions on how to access the course are in the link below. It's www.micropharm.uk, the website. Thank you for watching, and I'll see you in the next one.
Right, so my name is Nkatia. I'm one of the clinical educators for calculations on the MicroPharm platform. And today we're going to be looking at estimates of kidney function. This should be really exciting for most, if not all of you. I think as pharmacists, we're hardwired almost to sort of really hone in on renal function. I think it's the one thing that we really get het up about. And it's unsurprising that looking at kidney function and estimating kidney function and often making recommendations based on that is one of the key parts of being a pharmacist. The other thing as well that I'll point out here is that making recommendations based on renal function is important, but it's also worth just thinking about the patient in context, thinking about trends in creatinine, thinking about what the pros and the cons are of dose adjusting and when you're dose adjusting. But we'll get into all of that really shortly. Again, I just want to remind all of you that success as far as the calculations component of the registration assessment is really based on understanding the questions. Know your question types. Each assessment is likely to include at least one calculation question involving each of the following in part 1. The other thing that I will also stress is that calculations are not impossible, and they are part of a pharmacist's day-to-day life in many different forms. Whether you're in primary care, whether you're in secondary care like me, whether you're in tertiary care, or whether you're cross-sector. You've done all these types of calculations as an MPharm student and were successful then. You are more than capable of doing them now. Remember your time management. Remember to think about the context of the question, and also remember to highlight parts of the question and really break them down so you can understand what the question is asking of you. A little bit of background here. Renal function, as I already sort of alluded to, is our bread and butter. We're really focused on renal function, and I think in part it's because we're very risk averse as clinicians. I think we like to err on the side of caution. And what renal function is it's a measure of how well the kidneys are working by using the clearance of creatinine as a marker. Remember that creatinine is a breakdown product of muscle. And remember that renal function can be used in the context of a patient to determine what dose is appropriate to avoid toxicity or underdosing. So if we think right back to the MPharm degree, where we think about that therapeutic window, below which it's subtherapeutic, above which it is toxic. And in patients with impaired renal function, what you find is that the clearance of certain drugs is reduced, and therefore at the same dose, we might be more likely to be on the higher end, i.e., that toxic end of our therapeutic window. What you may also find, though, is that there are some patients with chronic kidney disease. And these patients, you may find certain drugs we might just use with caution. We wouldn't necessarily hold them, but we might dose adjust them. Sometimes we might watch and wait. Sometimes we might not dose adjust at all if the drug isn't cleared renally or metabolized renally. So a lot of different things to think about here. Again, remember that your key points are to remember that the factors between men and women are different. So in men, the factor is 1.23. In women, it's 1.04. Okay. Also remember, and this is just for general practice, that a serum creatinine that is high does not always indicate there's a problem. I always like to use what I was taught as an MPharm student is that classic Dwayne the Rock Johnson versus a little old lady called Sheila. That little comparison. Okay, obviously Dwayne the Rock Johnson's got loads and loads of muscle, so if he has a really high creatinine, then that doesn't mean he's got kidney failure. It's just a lot of breakdown of muscle. Whereas a little old Sheila, who maybe weighs 35, 40 kilos, very small, very frail, has a high creatinine, that's a fairly good proxy that might be something wrong because she might not have that much muscle mass at all. Okay, but again, we don't treat numbers as pharmacists, we treat people. So it's really important to think about the context of the patient in front of you. But let's look at the question itself. So we have Mr. B, and Mr. B is a 70-year-old man who weighs 82 kilograms, and he's found to have a serum creatinine of 164 micromole per liter. Using the Cockcroft and Galt formula, estimate Mr. B's creatinine clearance. I want to give your answer to the nearest whole number. I want you to pause the video, give yourself 3 minutes. When time is up or when you're ready to go through the answer, press play. Okay, I think we're good to continue. So, the first thing that I'd probably say here is just note down the fact that Mr. B is a 70-year-old man. So in this instance, we're going to use a factor of 1.23. He's male. So we have his age as well. And we also have his weight. And we have a serum creatinine. So 140 minus 70 times 82 times 1.23 over 164 micromole per liter. The calculator gives us an answer of 43.05 mil per minute. The question wants us to give our answer to the nearest whole number. The nearest whole number is 43. So our final answer is 43 milliliters per minute. Okay. The key thing is firstly to remember to answer the question. If the question wants you to give your answer to the nearest whole number, don't give it as a decimal because that is not necessarily the nearest whole number. Okay. I guess it's not a whole number because it's a decimal. And also just make sure to note down the appropriate information. Okay. And use the right factor. Otherwise, I hope that makes a lot more sense with regards to calculations involving estimates of kidney function. Remember, if you need any more support, the MicroPharm team are here to support you. But I wish you all the best in your revision and preparation for the calculations component of the registration assessment. Right, so hello everyone. My name is Enkatia. I am one of the clinical educators for calculations on the MicroPharm platform, and in today's session, we're going to be focused on displacement values. Admittedly, displacement values or displacement volumes are an area which we don't really utilize all that often because most of us don't extemporaneously dispense anymore. And that isn't to say that we don't make up solutions, so co-amoxiclav, we still reconstitute. And I suppose to that extent, when the directions say add a specific volume of water to your co-amoxiclav, that certainly involves the science that underpins displacement volumes. But we don't necessarily extemporaneously dispense suppositories anymore. And I think that's a certain type of question which a lot of candidates think about by default. What I need to remind all of you is that this is still an area of the GPhC registration assessment that can still be assessed. And so even though some of the questions may feel slightly dated, there are still practices that we use nowadays, if not by us, then certainly by other clinicians such as nurses, who will reconstitute and add specific volumes of diluent to specific dry powdered drugs in order to make them administrable, if you want to put it that way. Before we go any further, I want to remind all of you that your success with regards to the calculations components of the registration assessment is really down to you understanding the questions. Know your question types. Remember that each assessment is likely to include at least one calculation question involving each of the following in part 1. I want to also remind all of you that calculations are not impossible and they are part of a pharmacist's day-to-day life in many different forms, whether you're in primary care, secondary care, tertiary care, or even cross-sector. Remember your time management. You've got about 3 minutes per question in the GPhC registration assessment, so make use of that. Remember about the context of the question. So this is not just a calculations paper. This is a pharmacy practice paper that happens to use calculations as a medium. And finally, make sure to highlight parts of the question. Break down the question into bite-sized chunks so you're able to digest the information and really pick out the information that's really of relevance to you to give you focus in answering the question. With all that said, let's get right into it. So the term displacement volume generally refers to the volume or the quantity of a solid occupied by the powder following the addition of a diluent during reconstitution. So for instance, let's say you had 5 grams of a certain powder. It could be that that 5 grams of powder displaces 5 ml of water. So if you were to add 10 ml, then the total volume would actually be 15 ml, because 5 grams displaces 5 ml of water. Generally, your displacement volume will vary between different drugs, and that can also include different strengths of the same drug or different brands of the same drug from different manufacturers. This is really important to remember because it can affect drug stability upon reconstitution. So do keep that in mind. Let's have a look at an example question. A 52-year-old has been prescribed aztreonam 500 milligrams to be given every 8 hours following an extensive consultation with microbiology. The drug is given intravenously and cautiously given the patient's penicillin allergy. The nurse is following the instructions on the vial and adds 10 ml of water for injections to reconstitute the 500, that should say, milligram dose. Given that the displacement volume of aztreonam is 0.2 milliliters every 250 milligrams, what is the final volume of the reconstituted 500 milligram vial? Give your answers to one decimal place. I want you all to pause the video, give yourself 3 minutes. When time is up or when you're ready to go through the answer, press play. Okay, I think we're ready to continue. So what's really important to note here is, firstly, the nurse is adding 10 ml of water of injections to reconstitute the 500 milligram dose. We know that the displacement volume for half of that, 250 milligrams, is 0.2 milliliters. So it would make sense that double the dose would displace double the volume. So 250 milligram displaced at 0.2, 500 milligram displaced at 0.4. Therefore, if 10 ml is added, then the total volume is 10.4 milliliters. And that would be your final answer. Thank you for listening. I hope that has made a lot more sense. If you do need any other further support, then the MicroPharm team are here to support you. But I wish you all the best as you prepare for the calculations components of the registration assessment.